Dear audience, dear chair, my name is Adolf Lichtfusz, and my PhD thesis title is Imaging and Intervention Strategies in Invasive Cardiac Procedures. I am a cardiac surgery resident at the Central Hospital of Northern Pest, and my vision is to achieve optimal outcomes for patients through precise assessment and tailored strategies in invasive cardiac procedures. And my mission is to achieve this vision, to identify individualized treatment approaches by advanced imaging techniques for patients with complex cardiac procedures. To achieve my goals, I have two ongoing projects. Both of them are conducted as a systematic review and meta-analysis. The first project is Transcatheter edge-to-edge repair does not improve left ventricular reverse remodeling in secondary mitral regurgitation. It's a systematic review and meta-analysis. Heart failure affects more than 64 million people worldwide, and mitral regurgitation is the most common valvular heart disease in heart failure patients, affecting almost 65% of patients with chronic heart failure and 50% of those with acute heart failure. Transcatheter mitral valve repair, or TMVR, or transcatheter edge-to-edge repair, is a possible therapeutic option for patients with severe mitral regurgitation with high risk for surgical valve repair. While TMVR has been shown to improve symptoms, it's uncertain if it's by reversing left ventricular remodeling. So our aim is to evaluate to what degree the TMVR procedures slows heart failure progression by checking its effectiveness on reversing left ventricular remodeling. We have two clinical questions. Our first clinical question is how transcatheter mitral valve repair influence heart failure progression. Our population is heart failure patients with mitral regurgitation, and we would like to compare the echocardiographic data from baseline to follow-up. And we hypothesize that transcatheter mitral valve repair causes left ventricular remodeling. And our second clinical question is, transcatheter mitral valve repair more effective than pharmacological therapy in slowing heart failure progression? Our population is the same, but we would like to compare the TMVR plus guideline-derived medical therapy to guideline-derived medical therapy alone. We hypothesize that transcatheter mitral valve repair has a superiority in effectiveness on left ventricular remodeling compared to guideline-derived medical therapy. We conducted a systematic search in 3 online databases, and down there you can see my search key. The first one is about, the first domain is about mitral regurgitation, and the second domain about the transcatheter mitral valve repair technique. We started with more than 9,000 articles, and we ended up with 38 articles. Before I show you my results, I would like to say a few words about reverse remodeling and to clarify what it is. So in heart failure, the heart muscle architecture changes, which causes the heart chambers to dilatate. This process we call cardiac remodeling. With adequate treatment, we can reverse this process, which we call reverse remodeling. The guidelines say that if a 10% shrinking happens, we can call the treatment in this aspect clinically relevant. First, I would like to show you the technical success rate, which we can check by checking at the grade 3 mitral regurgitation before and after the intervention. Before the intervention, the proportion of grade 3 mitral regurgitation was 99%, and after the procedure was only 9%. So we can call this technique technically successful. For our first reverse remodeling outcome is left atrial volume. We used as an outcome measure mean difference, which was minus 5.70, which was not statistically significant, and the heterogeneity was high in this case. Our next parameter is NT-proBNP. The heterogeneity here was moderate, and the mean difference was more than 1000, which we can call statistically and clinically significant and relevant. Here you can see that we had many echocardiographic parameters, although we had many statistically significant ones, only NT-proBNP was clinically relevant. In the second clinical question, where we compared guideline-derived medical therapy to TMVR plus guideline-derived medical therapy, we had no statistically significant results, neither clinically relevant results. Our study has strengths and limitations. As strengths, we can say that we had a high patient number, many different follow-up periods, and a unique study design. And as limitations, we can say that we had only 2 RCTs and a few studies with long-term follow-up more than 12 months. As a conclusion, although TMVR procedure was technically successful, there was no clinically relevant change in the main echocardiographic parameters, nor any significant differences in cardiac reverse remodeling favoring TMVR. As an implication for practice, we can draw attention that the benefits of TMVR in cardiac reverse remodeling may be limited, so act as such. And as an implication for research, we can draw attention to identifying which patients benefit more from TMVR and explore other factors influencing its effectiveness. Also, high-quality randomized control trials are needed. We submitted yesterday our article to our second journal, and we are waiting on their response. Our second project is epi-aortic ultrasound in cardiac surgery, reducing perioperative stroke risk through improved aortic assessment. We also conducted this as a systematic review and meta-analysis. Stroke in cardiac surgery affecting up to 5% of patients significantly increases mortality and healthcare costs. Atheromatosus plaques in the ascending aorta is a major risk factor for perioperative stroke due to embolization during aortic manipulation. It is often undetected. Epi-aortic ultrasound is an intraoperative method which provides direct visualization of the aortic valve and on the atheromatosus plaques. Using this technique, we can adopt the operating strategies such as altering clamping sites and switching from CABG procedure to an OPCAP procedure, for example. So our aim is to evaluate the effectiveness of epi-aortic ultrasound in reducing perioperative stroke risk in patients undergoing cardiac surgery. Our clinical question is the following. Does the use of epi-aortic ultrasound in patients undergoing cardiac surgery reduce stroke rate? Our patient population is patients undergoing cardiac surgery involving manipulation of the ascending aorta. As an intervention group, we plan to choose studies, patients with epi-aortic ultrasound, and as a comparison, we would like to choose standard assessment methods such as digital palpation or transesophageal echocardiography without epi-aortic ultrasound. And our outcome parameters are stroke rate and perioperative mortality. We hypothesize that epi-aortic ultrasound reduces stroke rate and mortality in cardiac surgical patients. As a clinical implication, surgeons can use an alternate operation strategy based on the findings of the epi-aortic ultrasound. We conducted our search in 3 online databases. The first domain contains the procedures, and the second domain contains epi-aortic ultrasound. We started with more than 11,000 studies, and we are at the full text selection at the moment. Thank you for your attention. A smooth sea never made a great sailor. Franklin D. Roosevelt.
So in the first study, these patients who were candidates for TMVR were high-risk patients,
yes.
right? So they are high risk for cardiac operation.
Yes.
And you have shown, or at least the data shows, that there is no difference in outcomes with TMVR plus guideline-derived medical therapy versus medical therapy alone. Since these are high-risk patients for surgery, would it be fair to say that we should drop this TMVR idea altogether because we are putting high-risk patients in even more risk by doing this intervention for no good reason?
Yes. So when we are talking about patients are not fitting for surgery, we mean open heart surgery, not transcatheter methods. But if we check that the TMVR didn't bring any benefit to reverse remodeling, it's not the whole picture, because it can improve the patient's symptoms and such on. So the reverse remodeling part is only just a little piece of the picture.
That's what I wanted to ask you, that is there any relevant information from these articles that the patient condition are clinically relevant? You said that there are interventions which are clinically relevant. What do you mean about this?
Yeah, so we focused mainly on the echocardiographic changes, but there are studies which shows that the transcatheter technique improve the patient's symptoms and the life of the patients.
What do you think about the biomarkers like BNT? Because I think it is simpler than the ultrasound examination, because it's not so subjective.
Yes. Surprisingly, a lot of studies which checked ultrasound findings didn't check NT-proBNP. So we had only a few studies with data on NT-proBNP. So, but the TMVR technique greatly improved NT-proBNP. Maybe because NT-proBNP acts faster than anatomical remodeling and histological remodeling.